Good evening. Welcome to Facebook Live with Door County Medical Center. I'm Dr. Jim Heiss, Chief Medical Officer here at Door County Medical Center. And joining me tonight, to my left, to your right, is Dr. Amy Fogarty, who's our Chairman of Pediatrics here at DCMC. And to my right, your left, is, which I don't know why I have to say that, but I do, which is fun, is Sue Powers, who is our Health Officer and Public Health Manager. So thank you both for being a part of this.
Thank you. Thank you.
So the program itself was entitled Guidance in a Time of Uncertainty for Parents of School-Aged Children. So what we'd like to do is, we'll just kind of have a bit of a conversation here, and then we certainly welcome your questions, and we'll do our best to answer all the questions that we can answer. But I thought what I would do initially is do what we've done on the many Facebook Lives that Sue and I have done over the last 18 months. You want to give us an update of where we are in the county with COVID?
Sure, I'd be happy to. So our daily case counts are now as high as they were last January. And across the state, most of the counties, 56 counties, are at very high COVID disease activity level, and that includes Door County. And then the remaining 16 are at a high level. And the surge of cases, unfortunately, now is comparable to the uptick we had last fall around October, November. We've not gotten to that high of a level, and I hope we don't, but the trajectory is headed that way. So despite having safe and effective vaccines and a greater understanding of the virus and the layered protection strategies, we have more cases today. And the rise in cases, everyone is probably aware, is driven a lot by the Delta virus, which is far more contagious than the COVID strains we dealt with in the past. So currently in Door County, we have 223 active cases. To date for this month, we've got 99 confirmed cases. We added a death and 2 hospitalizations.
Okay.
I wish I had better news.
Yeah, so certainly we've noticed that too here at DCMC as the amount of testing has certainly gone up. Our testing center has been quite busy over the past number of days, and as you said, a number of positives as well. Our hospitalizations have not necessarily gone up. We've seen steadily about 2 to 3 COVID patients in the hospital, which of course I'm happy that it's only 2 to 3. I wish it was none. So that's a good thing. But let's get right to the topic at hand, which is just sort of talking about the uncertainty that's around COVID and schools and what do we do and decisions that each of the school districts need to make related to that. So I guess I have a question. A lot of parents have been asking, and I think it's a good question. It's kind of a broad question, but maybe for Dr. Fogarty, for Amy, how can I keep my child safe related to COVID?
Yeah, that's a good question. That's something that I hear on a daily basis in my office, and I think when it comes from parents, oftentimes there's different meanings behind that. What do you mean in terms of keep your child safe? For some parents, especially for those who may have underlying medical conditions, they're worried that their child's going to get the virus at all. For other children or other families, they're worried that their child is going to come home and give the virus to a more fragile adult. And for some parents, it's their meaning of safety is keeping their child in school because they don't want their child to have to be quarantined for days on end and then worry about either extracurricular activities, loss of instructional time, lack of socialization with their friends. And so it has a very different meaning for a lot of different people. And in the end, the answer to all of those questions is really 2 things. If you're vaccine eligible, get vaccinated, because it eliminates a lot of those issues that we work through in terms of, if you're vaccinated, you are asked to wear a mask in school if you're a close contact, but you're allowed to stay in school, and you're even allowed to participate in some of your extracurricular activities, as long as you're not having symptoms. And for those who aren't vaccine eligible, then wearing a mask and having the people around you wear masks or be vaccinated. And those are the really 2 most effective strategies. And I get asked over and over, is there something else? Is there something different? Have you learned anything new? And The answer is, I wish I could not have to continue to say, wear your mask and get vaccinated, but those are really the most effective strategies that we have. And we have learned. So last year, and I think, some of us kind of forget sometimes, but last year at this time, the schools were doing all kinds of other mitigation strategies. Mm-hmm. So there was a lot of talk about, ventilation systems and putting up shields and those sorts of things. And we found that if you kind of just plant yourself on with those two cornerstone ideas and those two mitigation strategies, along with making sure that sick kids are kept out of school, then a lot of those other things matter a little bit less. And in fact, we haven't, when you're doing those things, you really can allow a little bit more freedom in terms of some of the other things like mm-hmm. extracurriculars, yeah. which are very important to kids and families.
Right. So when it comes to contact tracing, things like that, Sue, what does public health do related to the schools? Are they involved in that, or? And I'm not asking that mm-hmm. as a planted question. I honestly don't fully know what's happening right now.
Okay, good question, and a lot of people wonder that. So when we find out about cases, we immediately begin a follow-up, and as you can imagine, we know the age of the person, but we don't know what school they go to or if they're in school. So for that, we need to, when someone's a minor, we always talk to their parent. So the first hurdle is actually folks need to answer their phone and converse with us for mm-hmm. us to get the information. And if somebody doesn't answer their phone, we make 3 attempts and then we mail them the information, and that's the very best we can do at that point. Mm-hmm. But going on, so when we get the parent on the phone, we find out, about the symptoms, when they started, where that child goes to school, what other things they're involved in. And the public health role at that point, if they're a student in school, is to find out what they do outside of school and who they were around during their infectious period, which is really important. Then we communicate with the schools, and they look at what that student did in the school setting or a school extracurricular. And public health can't possibly know those things. Mm-hmm. We need the school's help for that. And it's a tough job for them. It's time consuming. They're frankly tired of it. And I know at public health we're pretty tired of this also, like everyone. But it is the way out to prevent spread of infection. So that's the basic process.
Yeah.
And then we recommend, of course, isolation for the full 10 days. Unless someone has symptoms longer, then of course they have to be excluded for longer. And the close contacts, their safest is a 14-day quarantine, but 10-day is another option. 10 days with monitoring of symptoms for the full 14. So the parent and the child need to monitor for symptoms. And all the school districts, the main school districts in Door County, have agreed on that 10-day parameter for come back to school then. And there's also an option to come back to school when you're a close contact after 7 days if you get testing on day 6 or 7. Then you can return on day 8. And if a school chooses to allow that, that's up to that school. That's kind of complicated for us to know when they had testing and all that, and to advise the school. So we ask that the parent present the proof of negative test to the school in order for that student to return on day 8. I think I got that a little long-winded on that.
No, that was good. I mean, I think it's it's there's no, I don't think there's any way to get around the fact that it's kind of a pain and it's a lot of work. And I think one of the things that I've heard folks say to me is, oh, come on, the kids really don't get sick. I mean, the risk is pretty low. Kids aren't really dying. I do find, just an editorial comment, I find it interesting that death is now the criteria for the disease. It's sort of like, well, you got into a car accident and you have traumatic brain injury and you can't really walk anymore, but you didn't die, so it really wasn't that bad. And I think that's the difficulty. But I think, would it be true, would you say, Amy, that it's not so much, yes, there's always a chance kids could get sick from my perspective, but that's not so much what we're as worried about. It's just a matter of trying to keep kids in school and protect, perhaps, like you mentioned, the more vulnerable at home.
Yeah, and I would agree with that. I think, like anything, though, the more times you roll the dice, the more likely we are going to be to have a serious outcome, which would be tragic for our community.
Right.
But there's a lot of, so we always talk about morbidity and mortality, right? So the mortality is when people die. The morbidity is the bad stuff that goes along that's not necessarily death. And I think that we can talk about that with kids' infections too. So the mortality is not likely to be high, but the morbidity that comes along with the uncertainty of school attendance and these quarantines, especially when there's not in place for a lot of schools a virtual option, which, I don't think that that's unreasonable. It's very difficult for teachers to teach in two different environments at the same time. But I think that recognizing what comes along with, for younger students, it's a matter of the parents needing to be home and how do you try to engage a 5-year-old or 7-year-old in the classroom when they're out for 10 days. For the older kids, it's a matter of trying to catch up and being on their own. And for them, a lot of it is the loss of social and extracurricular activities too. It matters a lot more to middle school and high school students and what they're able to do in their time after school than it does maybe to a younger child. And so thinking about that and as a real cost to the contact tracing and the need for quarantine, because it's difficult for families to not know when the call is going to come in that their kid has to be out of school for a period of time.
Yeah. And, we've sort of been following what American Academy of Pediatricians, American College of Physicians, and the CDC, a lot of these colleges, these regulatory bodies, which might not be the right term, they recommend masking in school. But I guess, are we talking about masking all year? Are we talking about, or might there be a path out early next year, like in January?
Well, from my perspective, I think that there is a path out, right? So even 3 months ago in June, we were feeling like we were at nearly a path out, right? So we were saying that vaccinated individuals didn't need to be masked, and we were feeling like we were moving in the right direction. And I think we will get there again. Unfortunately, with where we are with a case positivity rate, we're not there right now. I think a big difference is going to be when all school-age children become eligible for vaccine, right? So that's going to make a really big difference because then again, those children can stay in school, even if they're being named a close contact, as long as they don't have symptoms, which makes a big difference for families again. Yeah.
Let's jump into a few questions that have started to trickle in. Do we test 6-month-old babies?
Yes.
Okay.
We test less than 1 day old babies when moms are COVID positive.
Okay. Here's a good question. I thought the CDC was looking at if one child wears a mask and the child within close contact also wears a mask. If one develops COVID, then the close contact child doesn't have to quarantine.
They actually have looked at it, and it's actually, there's an asterisk if you look under the CDC guidance for K through 12 school reopening. That was actually put forth. That idea was really gaining speed way back in June. It was something that I talked about then at a school board meeting. And what happened was there was a group that started to collect school data, and they really looked, and they found that if students were 3 feet or more apart, so this isn't even 6 feet, but 3 feet, and both students were masked in what they called typical classroom contact. Okay, so there's a couple of caveats with this, right? So typical classroom contact is not a basketball game. Okay, it's not eating lunch without a mask. It's sitting how we would typically think of in desks 3 feet apart with both masks on. Then there was a less than 1% chance that the positive student gave COVID to another student if both of them were wearing masks during the school day. So that is actually active guidance, and it is what schools who are requiring universal masking are using as their quarantine guidelines, which is why the burden of contact tracing and quarantining is significantly reduced. Reduced to almost nothing except extracurriculars or outside atypical contact for the schools that are requiring universal masking. And that's the big carrot, right? That's the big incentive. It's hard to wear masks. I don't like wearing a mask. I don't like saying that other people should be wearing masks. It's difficult. But at the end of the day, in general, kids are cool, right? I'm a patient. Kids are cool. And they don't mind wearing masks. They mind not being able to go to school. That's what they mind. Yeah. And if you ask them, and if you actually look in a classroom, last year we had this debate a lot. How am I going to get my 4-year-old to wear a mask? That was a common question. We answered on Facebook Live. And it turns out they do really well doing it. And but that's a huge incentive that parents and schools need to take into consideration if our goal is to provide daily in-person instruction on a regular basis.
It's kind of funny when you say that kids are cool with masking. It's sort of ironic. I mean, just from my perspective, kids are cool with masking. Many adults are not. And those same adults are the ones that are kind of stamping their feet and holding their breath until they sort of get what they want, right?
Yeah.
I mean, so it is kind of ironic. I mean, and obviously that's not, that's an overgeneralization, but, we have found that through COVID, if you don't have a sense of humor about some of this, it's, if you don't laugh, you cry, as I always say.
The other big incentive, and I really like how you explain that, the other big incentive is there is going to be less disease transmission at school if we all mask, and less disease transmission in our community if we all mask when we're indoors in public places.
Yeah, absolutely, yeah. And that's huge. I think the other thing that we should probably touch on, maybe we'll get to this in a question, is because you had asked about how long do we need to mask, right?
Yeah.
And another thing that's come out is so nobody's really satisfied with not forever, right? Well, we think.
Right.
But I mean, some of the things that we can really, really look at are thresholds with active case rates, and how that, when the hospital starts to become overwhelmed, is one data point we can use. And the other data point we can use, and what the school medical advisors are really recommending, is when you have what we call secondary transmission. So some schools will call this intra-school transmission. And so what this is if you're going to have positive cases. There's going to be positive cases. But it's what happens as a result of that positive case. So if you have a 7-year-old that comes to school and then the following day tests positive for COVID, does it stop with that 7-year-old, or has that 7-year-old given it to 5 other 7-year-olds? And that's the data. That's what Sue was talking about with the increasing contagiousness of the Delta variant, is that one person, on average, that comes in will give it to 5 more people. So you can see how rapidly this is going to get to be a problem in the classroom setting, where if one 7-year-old comes in and there's no masks and gives it to 5 more people, and then those 5 in that classroom give it to 5 more people, you can very rapidly see how we start to have a lot of difficulty with high numbers of kids that are needing to stay home for being quarantined.
And this is the big difference with the Delta variant, is the infectivity. The fact that the spread is so much quicker. You had, with the early part of COVID, you had maybe the equivalent of some green stick branches. Now you have dry tinder. And so it's much more likely to spread as a result of this. We call it the R0, which is R sub-0. And again, just infectivity, and it's a huge thing that I think we've found to be the case. You mentioned it, and I want to kind of touch on it. Someone had asked, any recent update on when kids 5 to 11 may be able to get vaccinated?
Yeah, so I'll share this. So again, I sit with the state group of school medical advisors, and we meet at least one Friday a month. And at our 2 meetings ago, one of the other people that's in the meeting actually sits on the Pfizer board, on the Pfizer advisory board. So right now, most of the press is looking at December. If you're reading, the New York Times or whatever. He actually feels as though the data will likely be submitted the end of this month, early October, with perhaps something as early as the end of October. Now, that would be on the optimistic side. I think the more conservative side and what's being published in the late press is probably December. But I mean, it's not a year away. It's not 2 years away. For the younger age group, it is going to be, spring of 22, probably at best. But it's something that's on the horizon. And again, when we talk about how long are we going to mask, right? So it's not that we're saying even for, there's not going to be anything we can do for this whole school year, right? Which is kind of where we were last year.
Right.
And we're not there right now, which is a really positive thing. It's what do we need to do just for a relatively finite period of time.
Yeah. And I do think, one of the messages that I try to put out there is, unfortunately, the reality of it is actually pretty simple calculus. I mean, the reality of it is, while spread is, I don't want to say allowed, but while spread is occurring in an easier way, this virus will continue to do its thing. And worse yet, what will happen is you let a virus sit to its own devices, it will mutate, start making more mistakes in its genetic code, which is what gives you variants. And so the worry is that there's just going to be more of this. And so, we would get to the end of this a lot faster. I mean, maybe I'm incorrect in this, but I always look back at June. Look at June. The effective vaccine started to really hit before Delta was able to pop up, and everything just plummeted. And I know we all sort of felt like, it was D-Day. We had all completely, we'd all kind of gotten through this, and now here we are back to an area that we didn't want to be. So, both of you, could you discuss the effectiveness of masking for kids? How does it compare when all kids mask versus when only a few mask? And how effective is masking? Are there differences in the effectiveness between mask types?
Sure. So I think to the first point, we don't have a lot of data on if it's 10% versus 20% versus 50%. What I'll say is that if you have universal masking, the rate of transmission in schools, because that's what we're going to talk about. So that depends on activity too, right? Mm-hmm. So there's very different transmission rates, even with masks, if you're talking about playing basketball as compared to sitting in math class. And that's just because of the type of contact. But again, less than 1% if you're talking about typical classroom contact, universal masking. And not masking, we know that a positive is going to give it to 5 more people. So that's where we're sitting, and to me those numbers are pretty easy to see. In terms of types of masks, anybody can answer this, but there are differences in types of masks, right? That's why as healthcare workers, if we know we're going to be exposed to a COVID positive patient, we wear the special N95s that we've been fit tested for. I'm wearing a level 3 surgical mask, which is what I typically wear out and about as compared to a gator or something.
Right.
And we're not saying that people need to walk around in N95 masks. I don't walk around in an N95 mask on a regular basis. We know that any mask is better than no mask, and certainly double layered cloth masks are very effective. And that's what we've been. I think that's a very reasonable option for kids to wear. And I've seen all kinds of very interesting patterns and styles, and people have gotten very, very creative.
It became a cottage industry.
Masks, matching outfits.
That's right. You had a tie, a pocket square, and a mask along with it. So
I'm thinking of the graphic you showed us at one school superintendent meeting.
Yes.
With, and I can't remember all the categories, but if both people are masked, it's the best.
Yeah, low risk. Yep.
Yes.
Or no risk. Yeah.
Next, less risk, or more risk rather, is one person masked and one not, and it goes down from there when you take off the masks.
Yeah. And maybe I could maybe send that on, and we could maybe put it as part of this video. It's a really helpful graphic. Again, I have to give a lot of credit to the state group of school medical advisors. They're the ones that pointed me to that graph. But it basically talks about what Sue was saying. I think there's 4 or 5 levels where you have both people masked and distanced, both people masks and a little bit closer. And then the next layer is if there's a COVID positive patient who's masked, but the other kiddo is not masked, versus the kid who's COVID positive is not masked, right? So that's the next level up. And even if the kid is masked, you're already in a high risk zone. And so that's where it's tough for parents, right? So if I choose to send my child with a mask, if another student is COVID positive, I'm still in that high risk transmission category. So you're automatically in a high risk, even through no choice of your own. And then, of course, the highest is when you have no masks.
Here's a question. How are the schools doing in Door County with the number of positive cases, positive in quarantine? You know, Amy and I and Brian Stevens, our CEO, went to the school board meeting last night in Gibraltar, so we know their situation. And I think we have numbers for the other ones, but we're going to be talking about those when we go to the individual school board meetings. But you guys want to comment on what we know for Gibraltar and what they're doing?
So Gibraltar has Gibraltar has universal masking. They've had no positive cases. They've had some students who have been out simply for testing, but they've had no contact tracing burden to this point. Now they just completed their 6th day of school. The other schools are having significant difficulties with a relatively high burden of contact tracing and quarantining to various degrees depending on the school district, but it is significant.
Sure. Let's see. What was your latest guidance to schools in addition to universal masking? Was it also about making seating charts to know which kids are in contact with others? I think that brings up a bigger issue. So, you taught me, I learned from you that there are different levers that you can we refer to, different levers we can pull as far as we talk about mitigation strategies and what things can we do to best mitigate the situation. And you were talking about there's different levers we can pull depending on the situation. Can you talk a little bit about that?
Yeah, so one of the concepts is, what mitigation strategies need to be used and when, depending on what your rate of, again, that secondary transmission is. So, how restrictive do you get in terms of extracurricular activities, in terms of what's done at recess, for example, or outdoor spaces? What do you do in indoor spaces? What do you do in indoor spaces during lunch? And using data to drive those decisions. And I've invited all of the school districts to participate in something called the ABC Science Collaborative, which are the people that collected the data about the student, about allowing for the modified quarantine when both students are masked. So it's a good group. It's a nationwide group, and Wisconsin Data was part of that. And so the idea is that we don't have to go all the way back to where we were in March of 2020, right? Where everybody's at home all the time, nobody goes anywhere. But we do have to, put in place different strategies at different times depending on what the data is showing us and what's happening. You can even go all the way down to, a classroom or a school building level in terms of deciding, do we need to universally mask? Do we need to alter lunch? Lunch is a really high risk period. Kids close, a lot of talking, masks are down by nature because you're eating. What do you do at recess? What do you do with high risk sports? And trying to decide which to use when can really start to be data driven, which is helpful. Not just quite such arbitrary decisions. In terms of the additional guidance that we're currently recommending, seating charts are really essential because, like Sue alluded to when she was going through what was happening with the contact tracing, we otherwise have no idea, say, who would technically be named a close contact for, let's just take a 5th grader, right, if we don't have a seating chart. And so without a seating chart, we're left with saying, well, everybody in the class is probably a contact, or you just don't know. And so then the whole class has to go home. And we certainly don't want to do that, right? I mean, we don't want to send any more kids home than what is absolutely necessary. And so what those seating charts allow is to look at, again, at that 6-foot distance and say, okay, these 3 kids out of the 20 are really the close contacts, as opposed to saying the whole 20. So that's why it's really essential for the school districts to help public health decide who close contacts are and to tell you what extracurriculars the students are in.
Going back to what you started out as, we've encouraged the schools to utilize the current data to make decisions about layers of prevention.
Yes.
And of course, right now, we ask them to use all those layers because things are, increasing as far as disease activity level.
Here's a really good question that I'm going to take a crack at, and you guys can chime in as well. So Stephanie writes, if the vaccine doesn't protect people from getting COVID or stop them from spreading it, but simply reduces the severity of symptoms, does it make sense to treat people differently if they're vaccinated? It's more for someone's own protection if they desire to get the vaccine, right? Also, then what comments do you have about that first part? There's a second part. Any comments, or should we move on?
I thought you were going to take a crack at it.
Yeah.
No.
Well, what I'm interested in is the second part. I guess I would say.
No.
I would say. I'll start. Then you can. I guess I would say. It does stop it from spreading. And wearing a vaccine does stop it from spreading. What was different about the Alpha variant, the sort of the wild type vaccine that was out there originally, is that there were studies that really demonstrated that there was really no fundamental spread if you were vaccinated. That was always the risk, but there was no fundamental spread. Delta, again, because of viral load, because you have that much more, it's easier to spread. So I don't know. I don't really have an answer about, does it make sense to treat people differently if they're vaccinated? I don't really get that. It's more for someone's own protection, the desire to get the vaccine. No, it's really not. I mean, I think in the end, what I would say to that is the way to get through the pandemic. We've said vaccines, but of late, there's certain experts in the field that I really listen to and trust. And one is Dr. Monica Gandhi. She's an infectious disease specialist at University of California, San Francisco. And she's kind of changed the wording a little bit to say that immunity is our way through. So part of this question too, which Stephanie gets to, is also what about natural immunity? And about natural immunity, natural immunity is very valuable. It really is. It's a very strong immunity. What we don't fully know yet, because there's not enough data to draw hard and fast conclusions on, is how long does that immunity last? But it doesn't mean that it's worthless. It means that it's actually very valuable. And when you take immunization on top of that infection, you've really increased the durability of that immune response. And I'll certainly let Amy take a crack at that as well. The other question is there testing for antibodies available? Would that make sense to check for antibodies? Yes, there are tests for antibodies that are available. The reason that we don't test them to sort of say, well, are you good for infection, is because antibodies are the first thing the body will make is an antibody, and they wane as immunity decreases. It doesn't mean that you're not immune. So you could have a low level of antibodies, but the body has a second wave of immunity, mainly in the form of what we call memory B cells. Those memory B cells recognize something and they jump into action. They put out more antibodies right then and there. So even if your antibodies wane and you get sick, those memory B cells are going to make more and get right on top of it. So that's really what the point of the second vaccine in the Pfizer and Moderna is to get that, really harden that second wave. Also, having had the illness, that starts you. That's like getting the first vaccine. And then once you get a vaccine, it hardens it. So there is some discussion too about, and with not good data yet, and you let me know if you've heard differently, that it's not unreasonable if you've been sick to get at least one shot. You're in probably pretty good shape if you do that. The recommendation continues to be, though, to get both, but if you only get one, it's not bad. It's certainly not worthless. So immunity is always important, whether it's natural infection or vaccine. The problem is if you take it to its conclusion, you can't just let a virus like this burn through the population. Because if it does, we know that the mortality rate is what, 1%? 1% of 350 million is 3.5 million people. We okay with that? Certainly affects the economy, certainly affects the communities we live in. But so that's why we have to think about better ways to become immune. So I don't know if you have anything you want to add to that little diatribe.
No, no, and I think the way that I think about the antibodies is, if your body made high levels of antibodies to every infection you were ever exposed to, your body would waste enormous amounts of energy and resources making that number of antibodies. Our immune system is super smart. And so what it does is it says, okay, we've got these little memory B cells, we'll just keep a couple of them floating around, and we're going to know that when there's an infection that they're going to get cranked, like you had said, they're going to kind of get cranked right back up again. And so that's how our immunity works to everything, right? That our body has been exposed to, is we have these memory B cells. And so unless you're actually measuring memory B cells, which would be the true measure of immunity, the antibody levels are not necessarily helpful, particularly antibody levels. I get asked this question a lot, or you'll hear statements, well, when my antibody levels fall, I'll go get the vaccine, and it's not particularly
it comes down to, I've gotten to the point where I hate the term follow the science. We say that all the time, and I've gotten to the point where I really dislike that because it's sort of become this throwaway phrase. And so it really is kind of like more, if you have a little bit of biology knowledge, that's kind of how it works. It's like when someone says, I want to wait till my antibodies drop, that's really not a completely effective way to measure. Now, Angie has kind of a long comment on here, and she is basically, just to paraphrase it, she is essentially, I'll just read it out loud. Bodies are built with immune systems. Most will do the job of building up and fighting this on their own. Mental health of children is not being considered when masks keep being forced. It should be and always is up to the parents. Even the exposure part, it's the parents' decision if they want to consider sending a child. So there's more, but I certainly respect when someone has an opinion. I would say I've heard the first part a lot about people will say, well, bodies, I have my immune system and I trust my immune system. The part that is misunderstood when you say that is your body has never seen this particular virus. This is one of 4 coronaviruses. That's why we call it SARS-CoV-2. It is a novel coronavirus. Your body has never seen this. Your body needs to see something first before it will develop an immune response. And that generally means getting sick with something. So what we're finding is because none of us, well now we have, but early on in the pandemic, none of us had been exposed to this. People were getting sick, and the body was reacting to it in a very, as you said, we have immune systems. The body was reacting to it in a very violent way, and people were dying and getting very sick and having long COVID and all these different things. Not everyone, but a lot. And so when people say, I have my immune system, I trust my immune system, unfortunately, I can't support that because that's not understanding how our body really works.
Well, I think that's...
You're the only participants in this conference.
I think that's an interesting thought, as long as you're the 99 out of 100, or even, and again, I think back to your comment, right? Like we measure this only by it seems as though this is one of the only things we measure by mortality. Like if you hear your neighbor has a heart attack, your typical response is, wow, are you okay? Right? Yeah. It's not, well, you didn't die, you must be fine.
Right.
And so there is a lot of morbidity, and I think that, I think in terms of considering mental health surrounding masks, again, I think that's almost an adult construct. When you work with kids and teachers in smaller classrooms, kids do okay with masks. I get a lot of, well, how are kids going to learn how to read emotions, particularly in the younger classrooms? And it's interesting, one of the pediatricians I was talking to said, well, children who are blind pick up on that just fine, right? Like they learn how to speak and how to read just fine, and you learn to use other things in order to pick up on social and emotional cues, like inflections in voice and those other types of things. And so I think I think that's a little bit of a reach. I also would suggest that needing to be home from school is difficult on kids' mental health, and in response to the parents have a right to choose. I agree, but again, back to that. So even when a parent chooses to send their child with a mask, they are still placing their child in a high-risk environment because other kids aren't masked, right? So you only get down into those lower levels of risk when everybody's masked.
Here's a good question I think both you and Sue can take a crack at. Can you clarify when testing is required for children? with allergy season here and cold and flu season coming up and trying to know when to be concerned. Are certain symptoms triggers for your child needing to be tested for COVID before returning to school?
That's a really good question. Yeah, and it's a hard one. What we recommend at Public Health is if the symptoms are different or more severe than their usual allergy symptoms.
Yeah, and some are easy, right? Like
Yeah.
allergies don't cause fevers, right? So
Oh,
that's
of
that's a
course,
slam
of
dunk,
course,
right? Or your child's never had allergies before, but we think that they're allergies. I will typically be an advocate for erring on the side of caution. My kids have been tested. I've been tested, and mostly because you don't want to end up in that, oh gosh, I thought it was just my allergies conversation, and then trying to backpedal through people that you may have exposed. And I've had so many of those conversations that I do think that my view is a little bit skewed, because I've had a lot of conversations with families where it's they open with, well, I never would have gotten tested if school hadn't made me, or I never thought that it was actually going to come back positive, or a lot of those kinds of statements when I was calling all the positive families. So I think that I like Sue, and that's what we've been saying too. There's the flow charts that most of the schools are using in terms of the 2 or more symptoms, which some of them can be related to allergies. But I really do say, if it's different than baseline, or your kid's been having this level of symptoms for a week and it's different than that, or certainly anybody thinking that this is like a new diagnosis of allergies, I think it warrants a test. And it's hard because you'd like to just be able to use medical judgment or parental judgment and say, I think that this warrants further testing. And until you get to we had the negative COVID test, it's kind of hard to move past that, because people are presenting with just such different symptoms at times.
And I can't tell you how many people we've had test positive that said, I was sure it was my allergies, or I always get sinus infections, I'm sure that's what it was. That sort of conversation, and they're shocked that they were positive.
And that's a really good point, because I simplistically, I usually, when someone would ask, before COVID, when they would sort of ask me, you think this is allergies, or do you think I have an infection, or do you think I have something, and I'll sort of say, well, do you feel sick? Sort of down to the base point. I mean, do you feel, and most people with allergies, they don't like their symptoms, but they don't feel sick. It's sort of a feeling that you have, but you're right. I mean, there are some times where people will have what they see as allergy symptoms, and they don't particularly feel ill, and they'll still be positive for COVID. And again, that just probably means they're going to have a mild case, but nonetheless, it's still then continuing this cycle that we have of the virus continuing. This is a great question, and I learned a lot from Amy about just this. Judy asked the question, students are masking in school but not in stores or restaurants. I've seen groups of kids unmasked. Kids have to be checked for COVID or masked playing sports, but fans and parents attending don't. So basically what I take away from that is the concept, what we were talking about of, so we're talking about, we're recommending masking in school, but what about kids that are at the store not masked? What about that?
It's a great question. And it turns out this is one we actually have a pretty good answer for. And this goes back to, people that have been talking to me in the last couple of weeks. I read a great book. So for those of you who are actually interested in reading it, it's called The Premonition by Michael Lewis. He's a nonfiction writer, he's a guy that wrote Moneyball and The Big Short and some other books. Anyway, probably slightly more popular books than but it was published in late spring, and it goes through a little bit of pandemic modeling. And so where do these recommendations come from? And it turns out when you really look at pandemic mitigation and spread, okay, so what are we able to shut down, and what causes it to spread out of control? It's remarkable to the point that they redid the modeling, and even looking at past data multiple times, how linked what happens inside school buildings is related to the subsequent mitigation and spread in the community. And it's interesting, but when you think about it, some of the data that kind of makes this a little bit easier to understand, people initially were thinking, oh, we got to shut down all the public transportation, right? So you think about where are people close, and automatically people start to think about, well, like the New York City subway system. Well, it turns out relatively few people ride the New York City subway system as compared to the number of kids that ride school buses. In fact, half as many adults use public transportation in the entire country as students ride school buses every day. And interestingly enough, those school buses are in every community, right? Public transportation is in our larger communities. And for those of you who don't like to read, that's fine. I would, if you ever look in a school hallway, you'll automatically see why this is true. Right? So if you've spent any time in just any school hallway, the proximity with which kids are, the closeness with which they are, particularly during middle and high school, like passing periods when they're walking through classes, or if you're looking at elementary kids as they're walking in and out of school, they're very close. I mean, I can't remember the last time as an adult I was sitting, here next to an adult, or whispering in ears, or showing people something on my phone, like in that close of physical proximity. And for kids, it's what they do tens or hundreds of times a day. And so because of that close proximity, that's why it matters so much what happens within the school building. And that's why we're also saying, let's take the universal masking to just what's happening in the school. Nobody up here is saying we need to shut down sports. Mm-hmm. We need to lock up the kids back in their houses like we were in March of 2020, right? Nobody's saying those things. And that's why if we can take control of these big areas of likely transmission, then we can let some of the other smaller ones, I don't want to say go a little bit, because you still have to worry about the quarantines, but the numbers are not going to be nearly where they are right now. And they're going to be something that's sustainable. And that's what we started to talk about when we were talking about endemic, right? Where we're just able to deal with this on an ongoing basis, and we're not worried about the hospitals being overwhelmed. We're not worried about schools having to shut down because of staffing shortages and all these other things.
Mm-hmm. That's great. Here's Angela asks, would a student be considered a close contact if 3 feet apart while eating unmasked in the lunchroom?
If they were there for 15 minutes, yes. Time comes into it too. If they were there for 2 minutes, no, unless they had actual physical contact, which, as you just described, could probably occur.
Fairly likely, right?
Yeah.
What do you guys think? Should schools be doing, this is a question that Aaron asks, should the schools be doing regular rapid test screening?
It's an interesting concept.
Yeah,
it's something
it
that
is.
a lot of places have utilized in certain scenarios. Probably the most common or the most well known was a lot of high schools were using it last year as we were approaching basketball state championship time. They were routinely testing athletes on an ongoing basis, either 2 or even 3 times a week. It can have its validity. It's difficult to logistically put that in place. I mean, if you have our districts here, 1,200 students, testing 1,200 students, even if you would take it on an every other day basis where it's 600 a day, and those tests are not the best tests, right? In terms of, so we talk about things like sensitivity and specificity, and a lot of times you're not, again, if you want to put your bang for your buck, right? Like, where are we going to put our resources? Mm-hmm. Putting our resources into surveillance type testing has really not in the larger districts that have done it. And again, there have been places that have done it even on a full district level. It's just not proven to be helpful or effective. Certainly not as helpful or effective as some of the other things that we can do.
Yeah, I read an article in the Wall Street Journal, and they talked about test to stay, I think was one, and it was a large urban school district, and it's kind of it's a neat thought. I know that it's we talk about how hard it is just to try and do some basic mitigation. I would imagine for the schools. I mean, it's a lot of work for everyone, and that would be even more. So not a bad idea. But,
and when you talk about what are we going to put students through? I mean, so just personally, there was a period of time that I was, a while back, last fall, I was helping out in our skilled nursing facility. Mm-hmm. And I had to be tested whenever I had to go in there. And I underwent that, I think it was 4 or 5 times. And I really started to, not necessarily look forward to that. So no. I don't know that I would be super excited if I was being tested on an every other day basis in an ongoing way.
Right.
I'll add that the state does offer a system for testing at schools. And a couple of our school districts have expressed interest, and I think one has tested some kids at school, but that's as much as I know about it. We saw that there was 5 test results from a school, so.
Yeah, it's been logistically a little bit. So it's a government program. Districts can sign up every Tuesday to have a testing make their school district really a testing site. The problem is that they're asking for the tests to be taken to a central lab, which has resulted in delays in turnaround. So what's happening is, as opposed to us just running our test here, that we collect the tests and then we drive it to a lab and then they run all the tests and then they get the results, which is currently running between a 24 and 48 hour turnaround, which is difficult. I mean, that's 2 days of school at least, right? So.
Okay, so I think we're about 50 minutes in. So I'm thinking I'm going to try this, and we'll kind of go around the table. What and this can be currently related to the schools or in general with COVID. What motivates you, and what's your reason for doing this work? Sue, we'll start with you.
Oh my gosh. What motivates me? Well, I really do want to keep the community safe. Mm-hmm. And I think, I'm the manager of the public health team, and they are a group of dynamic women, mostly younger than me. And I love to see the work they do. And what really keeps us going is when something goes right, or you get somebody on the phone that appreciates the contact tracing and wants more information, or it's unbelievable. Some people call and ask for information before we can get to their case. That's really fun. And I think sometimes the negative voices just get louder than the positive ones. Mm-hmm. So, those things keep me going.
Well, thank you for everything you do.
Thank you.
Amy?
Well, I think I've been called passionate to my face when it comes to things. I'm not sure what else has been said, but no, and to me, fundamentally, I am passionate, and I've spent my life advocating for the health of children. And when it comes to school, I will admit it's very easy for me to get emotional, and I do it because there are very few things that affect the health of children in the way that education does. Mm-hmm. So I get emotional about that because I see my job as being the one that it has the voice and is advocating for kids and trying to get them to the places that they need to be healthy and productive adults, right? That's the whole job of a pediatrician. That's like number 1 in the job description. And so that's what motivates me, to try and give them the best opportunities that they have to develop the gifts that they've been given to be the best people that they can be. And most certainly, I work very closely with educators, and I think we often see eye to eye in terms of we have very, very common goals, and working together to try to make sure that kids are everything that they can be.
Mm-hmm. Very good.
And what keeps you motivated?
Oh, you
don't get away with that answer.
You're going to move along.
No, I think I think I went into medicine. Medicine's a second career for me. I went into medicine a little later in life because it really just it was important to me to do, and it sounds sort of trite to say to help people, but I mean really. I want for people not to be afraid, not to suffer, and sort of to live fruitful lives. And so, one of the things for me with this pandemic that's been the biggest shock, when we were first in this work, keeping our head down, taking care of some of the first COVID patients in the hospital, when I became aware, mostly on social media, on Facebook, of all of a sudden there were these accusations that this is fake or this is overblown and things like that, I was never so blindsided in my life. So it really, for us, it's really a matter of we want to give the best information that we can give based on concrete data, not supposition, not, I've read it somewhere, based on concrete data, and that data is ever changing. And so part of what I want to do too is try to keep as up to date as I can and try and put that forth in a way that's helpful to the community, because one of the really neat things about living in a more rural area is that your community is your family. And so one of the things that I will admit to what's heartbreaking to me is seeing some of the divisiveness. And people have really dug their heels in based on certain positions, and everyone is entitled to their opinion, but I think what we really want to do, I know all of us, I think none of us said this, but I think we're all in the same boat. And what motivates me right now is getting out of this pandemic. When we say making it endemic, it means like turning coronavirus into the common cold. That's what we want to do. And by ignoring the evidence or choosing to disbelieve the evidence, that's just cynicism. And there's no cure for cynicism, and it's going to prolong the situation. So I really hope that Door County's done an amazing job of becoming vaccinated, 71% I think it's 90% of people over 65, 90+%. So we're still number 2 or 3 in the state. So I think this is a wonderful community. We've done a great job, and we're going to keep trying to be out there and provide the best information we can. So, Dr. Fogarty, thank you very much for joining us.
Thanks for having me.
Sue, thank you as always.
Thank you.
Great to see you again.
Thank you for hosting this.
Before we go, I want to put a plug in for an informational tab on our website that you can get to. We've created a resource that we really hope will help walk you through the process of what to do when or if your child becomes COVID positive or is a close contact with someone who tested positive. I'm just going to say the website, but basically if you go on to dcmedical.org, you should see it. But the actual website is dcmedical.org/coronavirus #students. Students, period, plural. So again, that's dcmedical.org/coronavirus #students. No spaces in any of that. And so hopefully that will provide information if you find yourself in a position where you need to sort of know what to do next. And we'll try and do our best to keep editing that and updating as we need to. So as always, I want to thank Mike Jarman and Aaron Shortall, who are behind the camera, which actually is an iPhone. So it's amazing what we're able to do these days, but Mike and Aaron are responsible for getting this going, and really appreciate their hard work as well. So I want to thank everybody and wish you all the best, and we'll talk again soon.